Right. So just to kind of review a little bit, just obviously, I came in complaining of left shoulder pain. My history was, limited. I mean, I basically complained of left shoulder pain. It's come on for a couple months with activity, and that's generally it. Then you go through you begin your inspection with a visual inspection. Then you start to palpate, and then you start to put me through ranges of motion, and you're collecting all of this global data. So you're not just touching my shoulder, but you're palpating generally, and you're checking general ranges of motion, and then you move on to the screening of the cervical spine, because like you said, ultimately you do have to rule in, rule out whether or not the cervical spine is a primary or major factor in this problem. Once that's done, or at least maybe before you do the cervical spine, from the collection of all the information, you're getting a syndrome kind of diagnosis where you're saying, okay, I have these symptoms and these neurologic signs that I've collected. This is what seems to be going on. This is what the central nervous system is showing me. Yes. Now we're going to see how much or how little the cervical spine is involved. And you treat my cervical spine.
I treat it. Now, one thing I must say is this. As we know, there are
Get a little closer to the microphone for me.
Sorry. There are two aspects that are perpetual stressors, so we must rule those out. The perpetual stressors are gas management and anti-gravity function.
And so as my wife will tell you, I'm very poor at gas management.
There you go. I will have to ask her to get a mask.
I just put a bag over her head. It's fine.
Well. I will leave that between you and your wife.
Okay, Go on. The perpetual is gas management.
Are usually the two things you must start to rule out. So posture is one. Look at the posture and see if it looks relaxed or constrained in some way. Where is the position of the glenohumeral joint? The humerus in relationship to the glenoid, the scapula in relationship to the thorax. Is this person's respiration strategy at all efficient, or is it likely to cause compensation? So those two, which DNS excels at, is to inspect and check. Do I have a gas or gravity problem, which must take priority because these stresses do not go away. Gravity and gas management are constant, continuous stresses. They must be managed. But once we have inspected that and done the test for that, if they're major players, we are going to be giving advice and training to manage those aspects. It may or may not include manual therapy. It definitely will include some kind of movement strategy instruction and giving the patient some tools to start the first aid treatment of those aspects. Then the rest is the more regional syndrome. It may be a global syndrome, it may be a regional syndrome. You could have come in and had Parkinson's. That would be a global syndrome.
Yeah.
Or you can come in and have a regional problem, which in your case was that your activities had led to some posterior contractures of the joint, soft tissue. The humeral head was forward. There were strains in certain muscles around the shoulder girdle. Your neck was involved, which it usually is in about 90, if not more, % of cases. And then, of course, and now you had an altered movement pattern and certain weakness in muscles and nociceptive chains. So you can have a global syndrome, a regional syndrome, or a local syndrome. You could have just hit your shoulder on something, and now you have symptoms from that. So it is important that we have an idea of what kind of syndrome I have. We've looked at what kind of problem it could be. Is it traumatic, anatomical, cumulative? Is there a major chemical factor or not in terms of inflammation? Do we have gas or gravity management problems leading or driving this further? Do I have a global, regional, or local syndrome? What tools do I have to treat all these? Once I've done that...
Well, in your case, it was manually torture me for 45 minutes.
It was.
Rub me to within an inch of my life.
Your very life. Yes. All that to help neutralize and improve the afferents from these areas to the central nervous system and get a better efferent output. Yes. After that, we can then look at the movement quality of basic fundamental patterns, which would be the developmental kinesiology patterns. Again, DNS now comes into its own in terms of I've used it for some treatment, and now I'm going to use it for movement evaluation. And I use that to see how do you use the global patterns and what might be defective. Prior to this, I will also have tested the muscle integrity of your shoulder, and I would also have tested the chains that move these limbs, and so I have to make sure that I have competent muscle function before asking you to do and demonstrate exercises. Because I must know that a muscle, if I ask a muscle to perform, it must at least give me the basic response, and that is to contract in time and then to relax. If it cannot do that, then my testing of you is a waste of time. Right. You already have deficits that are going to make you fail the test. So when I'm looking at the DNS tests, I'm hoping I can use them to ferret out poor chains. I can use them to ferret out poor movement patterns. But when I'm ready to use them as exercise and testing what you can do, I should have cleaned up all these problems in terms of the systems that go to make up good movement possible, which means that if I had fascial restrictions or nerve compression or contractures around a joint that was working, I would try to work with that. I can still use the DNS to do that, but I would use that, and now I will ask you to perform the voluntary building block movements to see if you're good at them or not. And if you're not, then I would instruct you in such a way to get a better proprioceptive, internally focused or externally focused movement strategy that would help repair this. We would use the positions, we would use handling, we would use the proprioceptive input, we would use more afferents, more support points, etc., by choosing the proper positions to give you a better motor execution and effectiveness. So that is really how I would look at the treatment of your shoulder. And that's why, you spend an hour trying to get as much of the preparation done so that on a subsequent visit, the movement strategy can be addressed. You can recheck all your baselines. You can see what is still missing, and you can move the patient forward based on the assessment on the day off.
If you enjoyed this conversation and want to hear more like it, then please like this video and subscribe to our channel. You can also stay up to date on our latest seminars on our social media pages on Instagram and Facebook @IMTR Seminars.